Okay. I want to welcome you to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, and I am the Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community, to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. Please visit www.persyst.com/grandrounds to keep up to date. Next slide. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. Next slide. Okay, there will be time for questions after the talk, and I want to orient you to the Q&A box at the bottom of your screen. You can type your questions there. We are going to wait until the end of the talk to address those questions, but please feel free to type in that box at any time. And we are also recording this webinar, and a recording will be made available to all participants afterwards. And so now I want to introduce to you Dr. Arnold Sansevere Jr. Dr. Sansevere is Assistant Professor of Neurology and Pediatrics at George Washington University. He is the Director of ICU EEG Monitoring and Co-Director of Neurocritical Care at Children's National Hospital. His research interests include using continuous and quantitative EEG to detect cerebral injury in critically ill children. And now I bring to you Dr. Arnold Sansevere for his talk, Clinical Applications of qEEG in the Pediatric ICU. Dr. Sansevere.
Thanks, Maria. And first, I just want to thank you for organizing this Grand Round series. It's really been wonderful so far, so thank you for that. Again, I'm Arnold Sansevere. I'm going to be talking about clinical applications of quantitative EEG in the Pediatric Intensive Care Unit. I know throughout the Grand Rounds, everyone has heard a lot about applications in adults and the adult ICU and in neonates, but this will be the first part of two lectures that will be given that focus a little bit more on how we're using quantitative EEG in the PICU. The only thing I have to disclose is that I am the co-editor of the Atlas of Pediatric and Neonatal ICU EEG. I have nothing else to disclose and no other conflicts of interest. There will be some figures from this atlas in the talk. So just to go back to our objectives, we're going to review quantitative EEG seizure patterns in the pediatric ICU. We'll try to expand a bit more on this and not just focus on the classic flame pattern that people are used to, but a couple others that we sometimes use. We'll then transition and talk a little bit about how we can use quantitative EEG to detect cerebral injury. And then finally, we're going to focus on some quantitative signals that may be helpful to detect increased ICP. And we'll go through a couple case series when we get to that point of the talk. So I'd like to start with this slide. This survey was done back in 2013. Looked at 11 Canadian and 50 US institutions. The majority of pediatric neurologists responded. And at that point, there was a 30% increase in the number of critically ill kids that were undergoing continuous EEG. And this is over 10 years ago. I would imagine that number is much higher now. For purposes of this talk, interestingly, bedside quantitative EEG was available in 14% of centers and 11% had nighttime capability. So what are some of the benefits and challenges of continuous EEG? So one of the big benefits is that it's really the one non-invasive tool that can provide continuous monitoring of cerebral function. It gives us very valuable information, especially when kids are in the ICU, they're on sedatives and neuromuscular blockade, and we don't have that examination to follow. You can display it at the bedside, but there are clearly some downsides as well. One of the big ones is that it's very labor intensive. This tool requires EEG technologists, epileptologists, and you sort of have to decide, all right, who's going to be monitoring this thing overnight. Due to that, overnight access in many centers can be limited, even in some large centers. And I find that real-time evaluation of raw continuous EEG, especially at nighttime, is really unrealistic. But I think those two last bullet points here are potentially where quantitative EEG can help. And we'll talk more about that. Before I get into this, I'd like to thank Dr. Benedetti from Seattle Children's Hospital for sharing this with me. This should be published in the coming weeks to month or so. Dr. Benedetti looked at 39 US and Canadian institutions. She sent out a survey to them. 56% of those institutions use quantitative EEG in their PICU, so much higher than what we showed from that study back in 2013. And 76%, sometimes or always, displayed quantitative EEG at the bedside. And I like this table here because it also focuses on what are the most common trends that are used in clinical practice. About 77% of respondents used amplitude integrated EEG. 58% would use the FFT spectrogram or CDSA, but others would use some of the other trends, specifically rhythmicity spectrogram. 54% of respondents would use that. For purposes of this talk, the alpha delta ratio was used in about 46% and the suppression ratio in 38%. So centers seem to be using some of these other trends as well, but not as commonly as the amplitude integrated EEG and the FFT spectrogram. So I know everyone has seen some rendition of this figure, but it just gives you a sense of how we get to the quantitative EEG. So essentially you have raw EEG. There are many different frequencies within a raw EEG, as everyone knows. The fast Fourier transform then breaks down those different frequencies and allows you to look at them in isolation. And then a power calculation is performed and focuses on the area under the curve. And then that can be displayed in a specific montage like you see here. So here, like all of the FFT spectrograms, you see time on the x-axis, you have your frequencies on the y-axis, and then there's this imaginary z-axis that displays power. So the warmer colors are the frequencies in which there's more power or more of that specific frequency, and the cooler colors are frequencies in which there are less of that particular wave. So as an example here, you see that red band, which represents the highest power, is seen around 2 Hertz. And then really above 5, you sort of see that those frequencies are not represented very well in the raw EEG, but you can see that this is how they get to the quantitative EEG display. And there are many different ways to display a quantitative EEG panel. This is one that I like. Here you have artifact intensity on the top, followed by that rhythmicity spectrogram. And the way that this works is that the left is always over the right. So here's the left side here, left hemisphere, right hemisphere. I also like to display the FFT, again, left and right. I like to keep the asymmetry relative spectrogram in our montage. And then you see here the amplitude integrated EEG, the suppression ratio, and then on the bottom, the alpha delta ratio. And you can change this to represent the number of hours that you'd like to see on a screen, anywhere from 30 minutes up to greater than 24 hours, if you like. So how can we use quantitative EEG in pediatrics? I think the most common use of it is seizure detection. At least that's sort of what many people, both here at Children's National, use it for, and many people being both critical care physicians, but also residents, fellows, and attendees. So I want to focus briefly on what seizures look like on quantitative EEG. And I think everyone is familiar with this, the concept of what flames look like. And flames are sort of the main signature of what a seizure looks like. And here we have the left hemisphere over the right hemisphere again. And to detect a seizure, we're essentially looking for an increase in warmer colors, that it evolves from low to high frequency. And you can really see that here. So it sort of starts off, you can see this, this red band here, or highest power, first being seen at a higher frequency, and then it kind of tailors down over time. So this is just an example of sort of that classic flame-like pattern that we look for when we're looking for seizures on quantitative EEG. So we'll transition to a case. So this was a 6-year-old kiddo with fever and status epilepticus. We put this kid on EEG, and he had frequent non-convulsive electrographic seizures. And all the pediatric people in the group have experienced this multiple times. This kiddo got every medication that we have. We started him on the ketogenic diet. We moved forward with anakinra, tocilizumab. This kid eventually went on to have a diagnosis of fires. Really not much was found despite a very thorough diagnostic workup. And this was his raw EEG. So this montage is left over right. So here's your left hemisphere, the midline, and then the right hemisphere. And you can see here on the right, there's this fast activity that was breaking through, and that would go on to evolve on the right. But then he was also having seizures coming from the left side as well. And these were happening, there's multiple seizures in an hour. So this was one example, or this is one example where quantitative EEG can be very useful in clinical practice. So again, here's that FFT spectrogram, left hemisphere, right hemisphere. And I also displayed the amplitude integrated EEG. And here's that classic flame-like pattern. You can see it's very prominent on the right side. You can see some of that field on the left. And you can see that this child has had multiple seizures in this time period here. And this is about 2 hours being displayed on the page. And then you can also see when you look at the amplitude integrated EEG, that red signal, which is the right hemisphere, there's a clear rise in both the lower margin and the upper margin, and those correlated pretty well with this flame-like pattern. So this continued. I like this page because it gives you, it sort of shows you that quantitative EEG can also help with localization to some extent. Here you can see on that right side, there are multiple flames, but then suddenly there's this left-sided flame, and that correlated with the left-sided seizure. What I also like about this is that here there's a change, and this represents a response to treatment. So this kid actually got a pretty big bolus of phenobarbital about 15 minutes or so before we saw this change. So when kids are having status, it really can give you a sense of seizures over time. You can get a sense of which medications they're responding to, potentially which medications they're not responding to. There's some practical use to this as well. It's sometimes hard to count 100 seizures if you're looking at the raw EEG, but here you can simply look at one page and get a sense of how many seizures a kiddo has had. So a really nice example of how we can use quantitative EEG in clinical practice if we're talking about seizure detection. This is another kiddo we had not too long ago, 16-year-old female. She had a presumed genetic epilepsy. She came in with increased seizures in the setting of a viral URI, but then the second day of admission, she had this new event. So she had this left-sided facial twitch that would last for several minutes, then self-resolve. So we put her on continuous monitoring to characterize these spells. So here we're displaying the rhythmicity spectrogram. So again, left over right, and also the FFT spectrogram left over right. So when I opened this page, the first thing that really caught my eye was this pattern here on the rhythmicity spectrogram. If you look closely, you can sort of see a remnant of a flame on that FFT, but it really was not as clear as the FFT spectrogram was here. So this is a nice example of another trend that can be useful if you're using quantitative EEG for seizure detection. And there's 2 hours on the page here, so you can see the number of seizures that this kiddo had quite easily. And this pattern actually correlated with this facial twitch that we've been attempting to capture. We compare it to the raw EEG, and you can see here that where you line up the concerning signature, you can see this rhythmic pattern coming through over the right side. And I can't stress enough the importance of confirming the quantitative EEG signals with the raw EEG. Artifacts can look exactly like seizures, and I think we've all been fooled by artifacts, even just looking at the raw EEG. So always confirm these signals with the raw. So I just want to take a couple of minutes and focus on some other patterns, and just keep in mind it's not just the flames. There are other patterns that can be useful. So here's a nice example of that rhythmicity spectrogram, and the black box focuses on what that should look like on the rhythmicity spectrogram. So if you look at the box on the right, you see that there should be this evolution, so this tailoring up of the darker signal to higher frequencies. Then you see this evolution over time, where it then transitions to those lighter colors and lower frequencies. So the one thing about the power spectrum of the FFT spectrogram is it's a little bit backwards compared to the FFT, or the ones that we're used to. So in this case, the more rhythmic waves are going to be darker. So the dark blue represents the more rhythmic waves, and then the lighter colors are less rhythmic. So here you can clearly see that this rhythmic wave peaks probably around 5 hertz or so, and then tailors back off. Just a nice example of something else that's not flame. They're not always so clear. They can be very subtle. So here is a nice example again of a more subtle signature on that FFT spectrogram. You don't really see as rhythmic or as dark of a signature here. And when you blow it up, you can see that it still has that same pattern where it's tailoring up and then tailoring down, but just not as clear as the prior example. I also want to mention the amplitude integrated EEG is not just for neonates. I find it to be extremely useful for seizure detection in the pediatric ICU. So here is an example of that. So just a brief reminder. So whenever you look at the background of amplitude integrated EEG, you always focus on that upper margin and lower margin. And a seizure is simply a rise in both the upper margin and lower margin. So in this instance, left hemisphere is blue, right hemisphere is red. All the asterisks are periods where there are seizures, and it's pretty easy to see an elevation in both the upper and lower margin. So here on the left, the dotted line shows that lower margin evolution, and the solid line shows that upper margin increase, and then the same is seen here on the right side as well. Just a nice reminder for everyone of other trends, specifically amplitude integrated EEG that we usually think about for neonates, but it has utility in pediatrics, the pediatric kids for sure. There are many ways to display this. Sometimes you can display it right on top of each other, and this just again gives you a sense of what that would look like. You can again see that rise in the upper and lower margin of both hemispheres, and then this figure up here just blows it up a bit more. So next case, we saw a 3-year-old young girl, very sad case. She presented after a motor vehicle accident, significant trauma, and this led to cardiac arrest in the field. The initial EEG was diffusely attenuated. She actually had stimulus-induced myoclonic seizures. The EEG became more continuous over time, and the seizures continued. So this was one instance where I felt that the amplitude integrated EEG was actually more telling than some of the other spectrogram, just because her background was just so rhythmic. So if you look at the rhythmicity spectrogram, it would be extremely hard to pick out a seizure from this background. I had a really hard time finding a clear flame pattern in the FFT spectrogram, but when we looked at the AEEG, it became a bit more clear. So here you see a very discontinuous background, but when you look closely, you can see that there is that rise in the upper margin, and also the lower margin. It's not necessarily a rise because of how discontinuous the background was, but it's pretty easy to see that there are definitely these periods of time prominent in the AEEG that were concerning for seizure. So when we lined it up, we found that there was this very rhythmic pattern occurring during each of these time periods. And this rhythmic pattern was associated with this eye opening, but also this twitching of her eyebrows bilaterally. And then this would continue for several minutes at a time. But quite easy once we sort of had a better sense of what what it looked like, specifically on the AEEG. It's a nice example of that. One thing I always tell the residents and fellows is that when you're using quantitative EEG, I always find that it's useful to confirm your suspicion with other trends. So if you look at the rhythmicity spectrogram and the the black arrow here, you see this little bump in these darker rhythmic waves. You say, all right, well, haven't really seen that before. That looks a little bit suspicious. It could be a seizure because you're seeing it more on the right side than the left, although it's still being seen on the left. So you look at that FFT and you say, all right, well, that looks suspicious. Is that a little flame there? And again, you see it's more prominent on the right side. So you say, all right, I'm not really convinced yet. Haven't decided yet to open up the raw because it's 2 a.m. And then if you look here at the AEEG, you can sort of see this rise in the upper and lower margin. And then over time, this becomes a bit more clear. So here, now your suspicion is very high because you said to yourself, all right, well, now it's really rhythmic on both sides. That flame looks a little bit better, and that AEEG looks a bit more prominent than it has. So this was confirmed as being seizure, but again, can't harp on this point enough. Always confirm with the raw EEG because artifacts can look very suspicious. There's been a lot of study with regards to qEEG and seizure detection. This is one of the more recent studies. So this is a prospective observational study of seizure detection in the PICU. It was real-time, so real-time seizure detection by PICU teams, and that was compared to seizure identification by neurophysiologists. 101 patients were identified. And out of the kids with seizures, 12 patients with the seizures were correctly identified, but 11 patients had a false positive diagnosis, so a pretty high false positive rate. However, the median time to seizure detection was 25 minutes, and you can see the range there, 5 to 218 minutes. And that's actually not too bad, especially at nighttime. So I thought this was a very interesting study, but it sort of shows that there is still work to be done with regards to that false positive rate. And this was a review that we published a couple of years ago now. Just looked at the studies that have looked at this over time, and some of these studies looked at CDSA or FFT in combination with AEG. Some of them were in isolation, and they looked at different or varying specialists that were looking at the trends. This varied from neurophysiologists to critical care doctors to bedside nurses. So the sensitivity generally ranged from about 70 to 83%. And the specificity range from 65 to 92% to detect seizures using qEEG. So again, I think that there is promise here, but work still needs to be done. So we know about seizure detection. How else can we use quantitative EEG in pediatrics? So the next thing we'll talk a little bit about is using it to detect cerebral injury. So this is a guideline from the American Clinical Neurophysiology Society, written by Dr. Herman and many of her colleagues. And it talked about what are the indications for continuous seizure. And we all know the main indication, which is detect subclinical seizures, because you can't do it without EEG. This guideline also talks about the use of EEG to detect cerebral ischemia. And it goes on to talk about the data in adults that shows that after subarachnoid hemorrhage, you can see signs of delayed cerebral ischemia using EEG, and lists all the different studies that have been done. It does, however, go on to say that while there's promise for using EEG to detect ischemia, it's sort of not really ready for real time or prime time, just because it's not necessarily feasible, and definitely not feasible, I think, in smaller hospitals. But it does say that this could be an indication for EEG. And most of the studies to date have primarily been in adults. There is some work coming out, but at the moment, studies have just been in adults as far as I know. So just to briefly go through some ischemia principles, and I know Dr. Herman gave a talk and went through this. The principles here are the same as they are in adults. Whether the details hold true is not really known quite yet. But as cerebral blood flow decreases, you'll see that your frequencies drop. So you can go from normal frequencies, you'll start to lose that fast frequency, that alpha rhythm. And then you start to get this increase in theta, increase in delta, and then ultimately there tends to be diffuse attenuation of the record. And, this is really nice for quantitative EEG because we talked about using power and specific frequencies. So if you go back to this, if you looked at your higher frequencies and compared those to your lower frequencies, then you can create this ratio. And most people are familiar with the alpha delta ratio. So that's just a ratio of the power of your alpha wave frequencies to your delta wave frequencies. And in early ischemia, you should see that those alpha waves will drop, and later ischemia, you should see more delta waves. And I must say, I don't necessarily think that the specifics of these ratios hold in clinical practice, because a lot of, especially in pediatrics, because a lot of these kids have extremely slow backgrounds to begin with. But you definitely see this signal in pediatrics, and I'll show you some examples of that. So keep in mind, left hemisphere is blue, right hemisphere is red. You can, again, plot this with time on the x-axis and then ratio on the y-axis. So this is a case, an 8-month-old normal male who had this unusual event concerning for seizure in the setting of viral gastro, comes to the emergency department, thought to be seizing, gets Ativan and phosphonatoin, put on broad spectrum antibiotics. Of course, that first head CT was negative, not surprising. An LP was performed that showed bacterial meningitis. So put on broad spectrum antibiotics, or continued on them, and then continuous EEG was started for concern for continued seizures. So the initial EEG was slow. There were normal sleep features, but then 5 hours later, we started to see that there was loss of that faster frequency over the left, and particularly there was loss of sleep spindles. So when we plotted this on the quantitative EEG, specifically looking at the alpha to delta ratio, we saw that there was this split in the left and the right hemisphere. And of course, that was super concerning to us, given this history. And then we looked at it a little bit closer and said, yeah, it looks like there's clearly been a change in this kid's EEG. So we performed a fast MRI, and lo and behold, this kid had a very large infarction. So another case, this was a 7-month-old who was status post cardiac surgery. Initial head ultrasound performed was unremarkable. This patient was started on ECMO, and as per our ECMO protocol, was put on EEG to again assess for subclinical seizures. The initial EEG was slow and symmetric. But then later in the course, neurology was asked to come to the bedside because this kiddo had a bulging fontanelle. And at that point, we got a head ultrasound, which showed this very large right frontal hemorrhage. So we went back and looked at the raw. And again, this is left hemisphere over right hemisphere. The arrows here, the blue arrow shows clear sleep spindles on the left. But when we looked further, they were not there on the right side. So again, very concerning, although we had already known there was a hemorrhage here. So we followed this over time, and we saw that after the spindles dropped out, we would see that there was this increase in slower frequencies in that right hemisphere. And then over time, there seemed to be some attenuation that would occur as well. We looked at the alpha to delta ratio, and we again saw that split between the left and the right hemisphere. And this was seen more prominently, really at least an hour, if not more, after the kid was put on EEG. And then this was an MRI that was performed, which again confirmed that right-sided hemorrhage and injury. So after a prolonged ECMO course, the neuromuscular blockade was eventually lifted, and this kiddo had a pretty good left-sided hemiparesis. So this was one nice example of where the quantitative EEG, particularly the alpha delta ratio, was very useful. And we've all been in this scenario where kids are, the paralysis is lifted and you get the call because the kid has this new finding on examination, particularly a weak arm or a clear hemiparesis. So another case here. So 8-year-old female presented with cardiogenic shock. This was due to suspected myocarditis. Patient went on to develop AFib, had a cardiac arrest, CPR for 30 minutes, and then was put on ECMO. We performed that initial CT, which was again unremarkable. put on EEG to detect subclinical seizures as per protocol. No clear epileptiform discharges. The record was symmetric. There were no seizures. So again, we looked at the quantitative EEG, and we just draw your attention to the bottom here where that alpha delta ratio is. And clearly you can see this split again between the left and the right hemisphere. So again, concerning if there was something else going on with this kiddo. We looked at the raw, and we started to see that there were some slow waves, primarily over the right side, kind of that right frontopolar to midline region. And then we performed the MRI, which showed that she had sustained injury. And again, when she was taken off a neuromuscular blockade, like the other kiddo, the exam was significant for left side weakness. So what about the ADR in pediatrics? This is some data that is currently in preparation, but we have started to look at this, and we retrospectively reviewed 49 kids on ECMO. Median age is 3.4 years. Majority of kids had peripheral VA cannulation. 45% of these kids had cerebral injury, and 18 of those kids had primarily focal injury. And the reason for ECMO, was mostly cardiac in nature, either heart failure or clear cardiac arrest, and some kids needing ECMO for respiratory issues. And as I mentioned, the main type was VA peripheral versus central cannulation. And there were some varying degrees of injury. Some kids sustained global injury alone, but that was the minority. Most kids had some focality to that injury. The EEG was kept on with a median of 43 hours. The 75th percentile was 66 hours. These kids were monitored for a fair amount of time. And then 33% had an asymmetry on their EEG. So we included all kids cannulated to ECMO. We included them only if they had EEG within the first 24 hours of cannulation. We excluded kids with electrographic seizures and extraaxial injury. And then we looked at the interhemispheric difference in the ADR, and we calculated this per patient at various intervals. So 1 hour, 3 hours, 6 hours, 9 hours, 12, and then 24. We performed a t-test to look at the mean interhemispheric difference between controls and patients with injury. We did not find a significant difference among controls in the approach to cannulation. So if you were cannulated peripherally versus centrally, that did not influence the alpha delta ratio. But we did see that there was a significant difference when we looked at controls versus patients with injury after 6 hours. So not at that 1 hour mark, not at the 3 hour mark, but after that 6 hour mark and beyond. So this is some evidence to suggest that in fact, we are seeing this signal in pediatrics, and the hope is that, it is reliable, and moving forward, this signal could potentially be targeted with whether it be hemodynamic optimization or other potential things, early imaging, etc. All right, so we talked about seizure detection. We talked about how we can use it to detect cerebral injury in kids, and now we'll focus a bit on if we can use it to detect signs of increased intracranial pressure. We'll start with another case. So this was a 6-year-old kiddo who had LGS, came in with for evaluation of recurrent fevers and weight loss. Seizure semiology was that of tonic seizures and head turning. Second night of admission, she was noted to have a right gaze preference and right-sided weakness. Very astute resident at the time said, well, that doesn't sound like her seizure semiology, so called a code stroke evaluation. We did a fast MRI and then put her on continuous monitoring because of her seizure history, just to make sure she wasn't seizing and that this didn't represent a seizure, despite the fact that the semiology was new and quite different. So you can see here that there's a lot of white matter abnormality throughout the brain. This MRI was concerning for an autoimmune astrocytopathy. This was new. This child had normal MRIs in the past. So we put her on EEG, and this slide shows the progression of that EEG overnight. So panel A shows the initial study, and clearly not normal. There's some attenuation over that left side in comparison to the right. Over time, there was some increase in rhythmicity of the waves. can see panel C, it starts to become discontinuous. And just to make the point here, this kid was not on any medications that could do this. Panel D, you sort of see that those discontinuous epochs now start to have a decrease in their amplitude. That continues on panel E, and then finally on panel F, there is diffuse suppression throughout. So we came in the morning and we got a phone call from a very astute EEG technologist. He said, you know, I think there's something going on here. We then went back and looked at the quantitative EEG, and I'll show you that in a moment, but I wanted to transition to another trend that I found to be pretty useful so far in pediatrics, and that's the suppression ratio. So the suppression ratio, the principle behind it is pretty similar. You've got a threshold of amplitude, and after you meet that threshold, you'll see a rise in either this line on the right hemisphere or the left hemisphere. So once you pass that threshold, that's when you start to see either the red or the blue line. So you can see here that there has clearly been a rise, and this is not that kid, this is just an example of a clear rise in that suppression ratio. And it's pretty simple to interpret. On the y-axis is just percent suppression. So you can see that this kid pretty quickly went to 100% suppression. Interestingly, this bump here is actually post-ictal suppression. This kid actually had not the kid I'm talking about, but this particular patient that I'm showing here had a seizure followed by post-ictal state and then went on to swell. So back to the kiddo that we talked about with the astrocytopathy. So if you focus on the suppression ratio, you see that initially over time, there was this baseline suppression, but then at approximately 7:30 or so, you see this clear rise in the suppression ratio up to 100% suppression. And it was at this point that she was scanned. And when we did the scan, right before she left, we were actually notified that she had bilateral fixed and dilated pupils. You can see that there's a significant edema throughout the brain. Another case, so this was a 6-year-old female with congenital heart disease, was on ECMO for presumed sepsis. CT scan was performed in the setting of this unexplained thrombocytopenia. There was some right frontal petechial hemorrhages, very small. She was put on EEG. It was unremarkable. There were no seizures. It was symmetric. The following day, we got a call because her pupils were non-reactive, and we repeated a CT scan. So here you see a large left-sided hemorrhage, clear midline shift, and she started to develop pretty diffuse cerebral edema. So we went back and we looked at her trend, and a couple of things catch your eye here. So a little before the middle of the page, you start to see that amplitude integrated EEG starts to become wider, so it becomes more discontinuous. And then if you look at that suppression ratio, you can see this very slow rise in suppression up to about 60%. And this was the time in which she was imaged. So clearly some signal was seen prior to the clinical change. And just for reference, there's 4 hours on this page here. So you're looking at about a 2-hour epoch more or less here. So probably at least 90 minutes, if not longer, she started to develop this signal. So we had a couple of those cases, so we said, well, we should put them together, see if there's some common themes. So we looked at 13 kids. The median age was 3.1 years. And we focused on kids that had either an imaging or exam finding of increased ICP. So whether this was herniation on an MRI or a CT or a blown pupil, those were the things that we compared the quantitative EEG to. The majority of kids did have a cardiac arrest. 100% of these kids, the EEG indication was to detect seizures. The start of EEG to the quantitative EEG change was about 19.2 hours, which with a higher IQR being 31 hours. We found that the quantitative EEG change in reference to the exam change was sooner. So the median was 2.1 hours sooner. There was one kiddo who developed a blown pupil prior to the quantitative EEG change, but the rest were after. We then compared that quantitative EEG change to the confirmatory image. The qEEG change was seen 6.1 hours median time before that first confirmatory image. and the range was 1.8 to 40.6 hours. So there was some delay, but for the most part, the quantitative EEG was seen before the confirmatory image. We then looked at the quantitative EEG change to the time in which the patient got 3% normal saline bolus for edema, and the median here was 3.7 hours. There again was one instance where the bolus of 3% was given before the quantitative EEG. We also looked at the duration of that quantitative EEG change, so the time in which the suppression ratio activated to the time in which it got to the greatest percent suppression. And the duration was about 3.4 hours with a range of 2.2 to 9.6 hours. So clearly enough time to potentially offer some kind of intervention, specifically bolus of 3%. We then proposed this protocol where we would potentially use EEG to look for increased ICP. And we tried to focus on some high-risk patients, such as the cardiac arrest kids, especially the kids with the infectious etiologies. I feel like a lot of these kids come in, they're oftentimes paralyzed sedated. They've got some presumed infection, and some of them do go on to swell. In that instance, I think there is potential for to influence outcome if you can identify a kid who's going to potentially go on to develop severe edema and maybe herniation. But based on our case report, we also included other kids, such as our autoimmune kids or suspected autoimmune kids. We said, well, if you have a new acute stroke or hemorrhage, you have a high chance of having reperfusion injury and developing malignant edema. So maybe that's a kid that we should put on. And then we sort of speculated with regards to how long they should be put on. We said 48 to 72 hours based on what we know about complications of certain things like strokes. And we said that could potentially be adjusted based on the length of paralysis and the timing of suspected injury. So something we just started to think about and have been attempting to implement here at Children's National. Not all of these indications, but some of them, specifically our cardiac arrest kids and our infectious etiologies. This was another case, a 5-year-old female with ethmolytic encephalopathy, came in with 1 week of diarrhea, had this low-grade fever, eventually went on to have an arrest, was intubated, started on vecuronium. There was a rising metabolic acidosis. Lactate was just rising almost by the hour. Initially, EEG was slow. There was no asymmetry. She actually had some vertex waves, though they were rudimentary, but no clear spindles. Initial CT was unremarkable. And then 24 hours after the admission, actually a little bit more, she had fixed and dilated pupils. So we went back and we looked at the trends, and you can see here on the left, the first period of time here, which was 2 hours, everything seemed to be okay. Attention is then drawn to that suppression ratio that starts to activate, but even before then, you can see that FFT starts to change, the amplitude integrated EEG starts to change. This continued over time. Here, this upper panel, you can see that there's loss of power in all frequencies, eventually leading to this very concerning pattern. The EEG at this point was diffusely suppressed, and that correlated again well with the suppression ratio. And then that just continued to occur until she got to 100% suppression and was completely flat. And this actually correlated pretty well with a fall in the pH, a rise in the CO2, and a rise in the lactate. But this was one instance where there was a signal seen prior to that suppression ratio activity. So this was another case report that came out not too long ago. They looked at 10 patients. The range was 23 months to 27 years. 40% had a CNS infection, 60% were intubated. And they looked at multiple trends: FFT spectrogram, the from baseline FFT spectrogram, which is new, the asymmetry spectrogram, AEEG, and suppression ratio. And this group found the qEEG change was seen 332 minutes before that clinical change, and the range was 201 to 456 minutes. They found that the FFT spectrogram was consistently the first change in 100% of their kids. And they also found that the from baseline FFT showed a subtle sign preceding the FFT change. They went on to note that the suppression ratio would rise in 60%. 60% of the kids who had a rise in the suppression ratio were found to have diffuse injury or global anoxia. just more data to support, or potentially support, the use of quantitative EEG for other things aside from seizure detection. And then this is the final case that I'll show, and then we'll open it up for questions. So this was a 22-month-old male who had a cardiac rhabdomyoma, had a resection and heart failure, required a transplant. Neurology was consulted after the arrest. This patient was put on ECMO. CT was unremarkable and was put on EEG, again, as per protocol for seizure detection. So we looked at our trends, and I draw your attention again to that alpha to delta ratio here at the bottom. It's pretty clear that there's a split between the left and the right hemisphere, and that was consistently seen throughout. There's also a change in the relative asymmetry spectrum that you can see here. You can see that there's a prominence of power over the left hemisphere. So day 2 of the EEG, we began to notice that in addition to the diffuse slowing, that right hemisphere started to attenuate. So here you see this attenuation of the entire right hemisphere. We repeated a head CT scan once we saw this, and you can see that there is evidence of infarction over the right, but also some other areas of injury that seem to be diffuse. So we then looked at the quantitative EEG, and we saw several different things as this progressed over time. So this kid had multiple CT scans within a very short period of time because of clinical concerns. But you can see that, you see again that rise in the suppression ratio here. That right side is more suppressed than the left, and you really have 8 hours here displayed on the page. You can see that the FFT spectrogram, the power starts to drop out globally. The asymmetry spectrogram, there's prominence of power over the left. And your AEG goes from being discontinuous to more and more discontinuous over time. So I like this case because it sort of displays, or it shows that there may be utility for a couple trends. So here's a kid who had a cardiac arrest, went on to have a stroke, then likely developed malignant cerebral edema, and went on to develop diffuse edema, and then ultimately herniated. So here we can see that initially that alpha delta ratio was split with a concern for infarction and injury. Then over time, this kiddo swelled, and we can see that on the suppression ratio, but also some of these other trends. So in conclusion, seizure detection is a common use of quantitative EEG. My sense is that it's the prominent use for quantitative EEG in the PICU. I think people are starting to use quantitative EEG for the other things that we talked about, but I still think seizure detection is what has been taught and what residents and fellows are looking at. I think a standardized curriculum could potentially help improve identification of seizures by non-neurologists, because I think that's going to be important moving forward, because as we talked about some of the limitations of continuous EEG, it's really hard to always have technologists or neurophysiologists looking at this study minute to minute, nearly impossible. Keep in mind, it's not just the flames, right? There are other patterns that we have in our armamentarium that can be useful. Always confirm with the raw, because artifacts are tricky at times. And then, we should keep in mind that quantitative EEG may have utility beyond seizure detection in pediatrics, but ultimately further study is really needed. There are limited studies in this area, and we need some evidence before we can really apply these things on a grander scale, I think. And then finally, I just wanted to thank a lot of different people, as always, nursing staff and admins. For those of us who do not have funding, it's really important that we have staff to help us to navigate and take care of some of our patients. So always thanks to them. The residents and fellows that are on the front lines that are doing all the work. And then all the different people over time that have helped me, Dr. Hurrah for being such a great colleague, and Dr. DeBacco for all help with the studies that I've attempted over time, and then just everyone else that has been there to help me move things along. So I thank you all for your attention, and I think we have a a good amount of time for questions if there are any. Thank you.
Thank you, Dr. Sansevere. Wonderful talk. Thank you so much. It looks like we do have a couple questions in the Q&A, so I will let you handle those.
Okay.
Let
So
me know if you.
the
first one I think is by Eva Catenaccio.
All right. So the question is, as quantitative EEG is used more in pediatric intensive care units, who do you think is the right person to be reviewing it, and at what intervals? Technologists, neurophysiologists, PICU physicians, frontline providers, nurses, etc. So I think there's not necessarily one answer for this question. I think depending on what each individual center's setup is, I think has sort of guides the answer to this question. I think in the ideal world, we would be in a situation where someone at the bedside, whether that is the provider, the resident overnight in the PICU, whenever they make their rounds, it would be nice if we can incorporate some kind of a review of the quantitative EEG into that. My sense is that a review every 3 to 4 hours is probably ideal. I don't know if that's realistic. It would be nice if at some point we could even incorporate at least a view of the EEG into the routine of a bedside nurse, but I think that would be really hard and in many ways unrealistic, just because of the amount of responsibilities that nurses have, especially in the pediatric ICU. But I still think that would be the ideal situation. I think it's unrealistic to have a tech on all the time, just because it is such a resource intense endeavor, I guess you could say. But I do think that residents overnight that are on in-house anyway, or review, them being sort of the front lines of review probably makes the most sense. But as we saw from the couple studies that we showed, I think there's still work to be done with that. But I also think there needs to be backup. So I think there needs to be some neurophysiologists on call that can confirm suspicion before acting on any change in the quantitative EEG. So hopefully that answers that. Let's see. Next question. Any way to exclude EEG electrodes not present or have artifact for persistent analysis? A lot of the ICU kids don't have a full montage or there is artifact. I will say this is a big challenge. Fortunately, in our pediatric ICU, our kids are getting a full montage. I think, quite honestly, it's challenging without that, unfortunately. I do think that the artifact algorithms that are used with Persyst are actually reasonably good. But I would again just reiterate the fact of artifact can definitely look like seizure, and that would need to be confirmed before any intervention could be performed. And then the final question, which I don't think I'll be able to answer, is there any way to add medication timing to Persyst analysis? I think there is a way to do it. We tried to do it with, the study that we showed, our case series. I don't know if there's some way to integrate that into the software itself, and I think that's probably the question.
So medication timing, yeah, how are you interpreting this? Just like when you give a medication, is there a way to synchronize that as an event?
My sense.
Okay.
That's true.
Yeah, you can add them as an annotation, and then they could be trended as an event density to indicate the presence of any comments. But there isn't an automated time synchronized way to do that. You just have to annotate a comment into the record. I hope that answers the question.
And then just to go back to, I guess the question was really about the ICU montage itself. Is that?
Yeah, I think so. So I'm reading these. Looks like I don't know if the person on Galaxy is the same person that asked a question before, but asking about ICU montages for adults, pediatrics, and neonates. I don't.
Yeah. We do go with our our full montage that is recommended by the by ACNS on pediatric kids. I don't know if that's helpful or not.
Yeah.
And then next question here, what is the role of quantitative EEG outside the pediatric ICU in patients with epileptic encephalopathy, tonic seizures, infantile spasms, etc.? I've used quantitative EEG in the EMU as well. I think it's depends on the seizure semiology. I've not found it that useful for spasms just because they are so brief, as you know. I do find that there is some utility in using it for tonic seizures, depending on their length. But not necessarily using it to judge the degree of epileptic encephalopathy, but other people may be using it for that. It's just not been my practice. And then a question about sensitivity and specificity compared to the raw. The only analysis that I know of looking at sensitivity and specificity has been for FFT. I can go back to that. The talk where we sort of said the sensitivity is probably 77 to 83%, with the specificity being 65 and above, but not as high as 85%. So that is typical range. And then the question is there a way someone could go back and watch the beginning of the presentation? My understanding is this is going to be available after the talk for you to review.
Yeah, that's right. If there's no more questions, I have one for you, Dr. Sansevere. I'm curious, it sort of relates to the first question about the review of the quantitative EEG. And I am curious how your center does it. You said, which I think is true, that it depends center to center. But how is it that you all handle the monitoring of the quantitative EEG? And you mentioned that you had a super tech who alerted you to something. So do all the techs monitor the trending? And how often do you do internal education to help make this a more seamless process for you and the patients?
Yeah, it's a great question. So currently at Children's National, our fellows are sort of the first line. So we have a night flip fellow that has many responsibilities, but one responsibility is covering the PICU and the CICU and the Neurology ICU. So it oftentimes is the case where they are the first line with regards to looking at the EEG. That said, there is always a neurophysiologist that is on as well, that is available for questions. So that's been our approach here. And with regards to overall reviews, currently we don't do as much as we would like. So these the residents and fellows get at least a yearly lecture about quantitative EEG. But a lot of it tends to be, we've seen a great case, and at that point we can sort of review it with whoever is on overnight. But we've not yet, and we're planning to, but we've not yet instituted a clear timeline with regards to, okay, we're going to be reviewing this every, X amount of months. Now, in the ideal world, or what I'm planning to do is I'm planning to set up set intervals with residents that will be coming on, especially if they're new to the pediatric ICU, where they just spend time with me and we review important charts. And I also have a quantitative EEG reference card that I'm planning to give to them with examples of not only seizures, but also some of these other patterns that we sometimes see. These changes in suppression ratio, these changes in the FFT. What does burst suppression look like on EEG? What does a low voltage and attenuated pattern look like on quantitative EEG? My prior institution, we tried to do something different with the technologists because they were at least available overnight, but the problem is that there are many other kids in the hospital that need their attention. And what I mean by that is the surgical kids. It's really hard for a technologist, and you're likely not going to get more than one tech on at night. It's really hard for them to be watching one or two surgical cases and also be responsible for the ICU kids as well. Like I said, it's difficult for sure. I do think that starting with training residents and fellows is probably a good way to start for sure. At least that's my take on it. So I'm not sure if that answers your question or not, but
Yeah, thank you.
And then there are efforts. I mentioned Dr. Benedetti is going to be talking at the next part 2 of this talk, and she's actually trying to organize some educational, standardized educational approach, which I think is going to be really important as we start to integrate this into the pediatric ICU. So.
Interesting. Yeah, thanks for bringing that up. I think, yeah, definitely. The next Persyst Grand Rounds is Dr. Benedetti, like you mentioned, and she'll be giving sort of a part 2 to what you started here. So certainly stay tuned for that. There was one question. Let's see. I think that I'm reading this right. Spike detection and auto something are right here with Persyst. I guess it's worth mentioning that the Persyst software package has automated spike and seizure detection. So I don't know if that was the question. And then the last one about a CME credit, you can get 1 CEU credit with ACET. If you, afterwards, we send an email confirming that you have attended the live event, and then you're able to send that email from us as proof and to ACET, and then they will reward 1 CEU. Unfortunately, it's only for the live event, so it doesn't count if you watch the recording afterwards. And let's see, is there anything else under that?
Another question here. So what
Yes.
about patients in whom we are targeting burst suppression, for example, with known ICP crisis? We're trying to achieve burst suppression to mitigate the crisis. It is done in rare scenarios, but we've definitely done a fair amount of that here. And have I found that persist suppression ratio is useful in the situation? And the answer is yes. I oftentimes will follow the suppression ratio in conjunction with the raw to get to the place where I want to with regards to how suppressed I want the patient to be. And I do think it's probably, definitely not worse for sure, I would say, but also probably not better. I think that it's better from the standpoint of I can just look at snapshots in time by clicking on different parts of the suppression ratio. But I find that both are probably equally useful. Again, it goes back to this idea of, suppression ratio is so easy to use. That's something that could be teach a critical care doctor to look at that if at your center they're integrated into how suppressed you want an EEG for a certain, whether it be ICP crisis or status epilepticus or whatever it is.
Okay, the next webinar, you can go to www.persyst.com/grand rounds. This is in response to another question. I believe I actually have to check it myself. It's usually the last Monday of the month. There are some variations according to speaker schedule. So let's see if that's true for the next month. It looks like Dr. Benedetti is going to speak Monday, June 27th, also at 11 a.m. Eastern time, so same time as today. And it's Dr. Julia Benedetti, Assistant Professor of Neurology at Seattle Children's. So that'll be another great talk, part 2 of this talk. So you can sign up on our website. Registration will be available when you receive the recording of this talk. So when you get the recording for this one, you can then go to our website and sign up for the next one. So I hope that answers all of the questions. And thank you very much, Dr. Sansevere. This was very educational for me as well. I always enjoy learning from each of you. I consider it an honor to be able to do this. So really appreciate your time. It is a service to our community. So yeah, and unless there are any other comments or questions, I think we have arrived at the end. So thank you again.
Thanks very much.
Okay, bye everybody.